I'm Emma Bilcock, occupational therapist for the Stroke and Neuro Rehab team. This is the presentation for psychological effects after stroke. By the end of this presentation, you should have an understanding of psychological well-being, what emotional changes include post-stroke, how psychological well-being can be assessed, identifying interventions, developing a toolkit of interventions, and describe how stroke can affect psychological well-being. Here are 3 questions for you. What percentage of stroke survivors experience depression within the first year? Is it true or false that emotional changes post-stroke have an impact of quality of life and rehabilitation outcomes? And within the first 5 years of a stroke survivor, how common is it for anxiety to be diagnosed? 30% of stroke survivors experience depression within the first year. A high proportion of this is undiagnosed and they have inadequate treatment. It is true that emotional changes post-stroke have an impact on the rehabilitation outcomes, and within the first 5 years, 25% are commonly diagnosed with anxiety. The frontal lobe, the yellow section on this diagram, and the limbic system are the 2 main areas that control our emotions. Depression can be a normal reaction to having a stroke, or it can be due to the damaged area caused of the brain, like mentioned before, the frontal lobe or the limbic system. 2 of the most common post-stroke effects are emotional and psychological changes. Up to 75% of stroke survivors experience depression. It does not have a time frame and can fluctuate. It can have an impact on reduced recovery, motivation, and quality of life. Increased hospital stay and social isolation. Anxiety is the feeling of constant worry, fear, and unease. Often, patients often say something's bad going to happen, but they're not sure what or why. Up to 30% of stroke survivors report an experience of anxiety during their recovery. Other causes of depression and anxiety can be loss of independence due to physical changes, needing a carer or family help. Loss of functional ability, relationship dynamics being a parent, a carer, an employee, adaptations around the home, and communication difficulties. Psychological care and well-being is key to stroke rehabilitation and recovery as much as physical rehabilitation. Post-stroke depression and anxiety are associated with higher rates of mortality, long-term disability, hospital readmission, and suicide. Recognising the signs of depression. Depression can show itself in a number of ways, both physically, socially, and psychologically. Physically, it can change the appetite of people, eating more or eating less, having a change in their weight, aches and pains from reduced movement, energy and fatigue affecting sleep patterns. Psychological changes can be feeling sad, hopeless, more irritable and tearful in situations, reduced enjoyment of things that you would normally otherwise enjoy, and suicide. Changes in social activities, such as change of relationship with family and friends and employers, avoidance, so avoiding people, activities, and isolating yourself, and this can also leading to difficulties at home within the family dynamics. Recognising the signs of anxiety. Anxiety, the same as depression, can show itself in different physical, psychological, and social ways. It can increase the heart rate physically, causing dizziness, breathlessness, sweating, opening the bowels, and fidgety and restless movements. Psychological changes can be leading to worried thoughts, reduced control of your thoughts, irritated and chaotic thoughts, and reduced concentration and attention to activities. Social changes can be communication speed, so talking a lot faster due to worries, or speaking a lot slower due to concentration. Snappy and irritable to people in different conversations or different activities. Increasing your activities to not have to concentrate on your thoughts, and changes in your general behaviour. Apathy. Apathy is when the individual has reduced lack of motivation, emotion, and feelings, which affects their daily interaction with occupations and leisure activities. Apathy can be a sign of depression or a standalone effect from stroke. Not everyone who has apathy is depressed. Approximately 35% of stroke survivors experience apathy post-stroke, and it is more likely to be evident in those with severe physical and cognitive impairments. Apathy is likely to get better with time, and also following a structure and a daily routine can also help. Behavioural changes. It is common for stroke survivors to experience frustration and anger more frequently than is normal for them. This can be due to the stroke or the damage to the brain, or their frustration with their post-stroke changes, physical, cognitively, or psychologically. Key to helping these changes is to understanding the triggers and learning how to manage them. Behavioural changes can be inability to read situations, sexual behaviour, and inability to make decisions. Emotionalism is also known as emotional liability. This is how stroke survivors manage their emotions and moods. Emotionalism can cause excess crying or laughing for no reason, and often at inappropriate times. This occurs in 10 to 20% of stroke survivors, and it is more common in the early stages of rehabilitation. Stroke survivors often find themselves more emotional than what is normal for them. This has to be taken into consideration with how emotional the individual normally is. Emotionalism is due to the area of the brain that the stroke has affected, and it can improve within 6 months. Here are some of the assessments of a psychological status that we use in stroke rehabilitation. The General Anxiety Depression Scale, the Patient Health Questionnaire, Hostile Anxiety Depression. A non-verbal assessments are depression and intensity circles, which can be seen in the picture above. Stroke Aphasia Depression Questionnaire Observational for 24 hours, which is the SAD-Q10, and a Visual Analog Self-Esteem Scale. The NICE guidelines recommend that the psychological status is assessed 3 times. These can be the 1 month after a stroke, or just before discharge, or at their 6-week follow-up. The second time the assessment should be completed is 3 months after a stroke, usually post-discharge, to find any early onset problems and any new problems. And the third one is 6 months after the stroke, when much physical and social recovery has happened and able to identify longer term problems. Here are some interventions and coping mechanisms for psychological well-being. Distractions can be listening to music, doing jigsaws, spending time with pets, or any activity the individual is interested in. Relaxation techniques such as mindfulness, deep breathing, muscle relaxation, and visual imagery. Therapy such as counselling and cognitive behavioural therapy, and onward referrals to neuropsychology. Listening. Listening is the acronym of SILENT. Do not fill the silence, count to yourself and allow for reflection, and the individual will fill it. Pay attention to body language, eye contact, nodding, and don't cut off the individual when they're talking. Reflecting, so mirroring a person's physical movements, paraphrasing what they are saying, and paraphrase the feelings that you hear them express. Explore and clarify, such as things like, how did that go? How did you feel after? And what did you do? And summarise the key points back to the individual that you got from the conversation. Suicide post-stroke. Stroke survivors are twice as likely to attempt suicide. As each year passes in their rehabilitation, the risk of suicide is reduced by 3%. 1 in 8 stroke survivors have suicidal thoughts. The language around suicide is changing. It is trying to be changed that you don't commit suicide, or someone doesn't die of committing suicide. They die of having suicide or doing suicide. Commit comes from the language of when it is a crime, and suicide no longer is a crime. And we also often say unsuccessful suicide, which is also trying to stop, as if someone passes away, it's a successful suicide, but it is not successful. The NICE guidelines, psychological care after stroke. Everyone involved in individual care. It is everyone's role in psychological care to monitor. NICE guidelines recommend this stepped care approach for people suffering from depression and anxiety. The NICE guidelines also recommend the hierarchical approach leading from level 1 to 3. There is no time scale for stroke survivors to be using this stepped care approach, and can fluctuate, so they can come in and out at any level at any time. Level 1 is a screening. Level 2 is for stroke survivors with mild to moderate results from their assessments, and level 3 is for severe complex psychological changes requiring input from the mental health and neuropsychology input. As the levels increase, the complexity of interventions increase as well. Here are some self-help books, and the website to get these is on the slide below. If you have any questions, please ask your trainer or email me on the address on the slide.